Good afternoon, everyone. I'm Dr. Sabyasachi Chakrabarti. My membership number is S16242, and my free paper is titled "A Blind School Survey: An Attempt to Identify Needless Blindness."
Timer, please.
None of the authors have any financial interest in the contents of this paper. So, introduction. Childhood blindness, although uncommon, is a huge social burden because of the large number of blind years it generates. Population-based data on childhood blindness is difficult to obtain because these entail evaluation of very large samples. This study is a blind school survey which hopes to provide a glimpse of the characteristics of childhood blindness in the South Indian population. Material and methods. The study site was a blind school located in Palayam Kottai, Tirunelveli, Tamil Nadu. The study population included all pupils enrolled either as a day scholar or as a hostelite in the school. The design was descriptive and cross-sectional. The aim of the study was evaluation of the causes of blindness and low vision in a blind school in a Tier 3 city to assist in the planning of low vision services. The objectives were to determine the different etiologies of visual impairment in children studying in a blind school, to determine the visual potential of candidates in a blind school, and to determine the frequency of avoidable causes of blindness. Data collection methods. Demographic data of the children and a brief family history were obtained from the school records and the staff. Distance visual acuity was assessed by OroChat, Orolab, Madurai, India. Refraction was done by loose lens retinoscopy. If the child failed the distance vision test but there appeared to be some useful vision left, tests for functional vision, namely independent mobility, social contact and near vision were performed. Trials for low vision aids were performed for all patients with low vision with at least some degrees of functional vision. The LVAs tested were high plus lenses, hand magnifiers, stand magnifiers and spectacle mounted magnifiers. So this is an LVA trial going on in the survey using a stand magnifier. The anterior segment evaluation was carried out with a torchlight. Fundus evaluation, if indicated, was done using an indirect ophthalmoscope after full mydriasis. So these were the techniques of anterior and posterior segment evaluation in the study. Statistical analysis. Continuous variables were summarized as mean and standard deviation. Categorical variables were summarized as frequency and percentage. And the data thus collected was analyzed using OpenOffice Calc for Windows version 4.1.4. So some descriptive statistics. The total population tested was 149 with a mean age of 12.13 plus minus 3.16 years. Males outnumbered females. Males were 91 and females were 58. This is the first pie diagram which shows the levels of visual impairment in the 149 surveyed children. Almost 52 children had a visual acuity of less than 1 by 60. Low vision was present in 57 and 76 were blind. This pie diagram shows the major anatomical site of involvement for visual impairment. Whole globe involvement was found in 42 cases, which included microphthalmos, anophthalmos, cryptophthalmos, and thysis bulbi. This chart summarizes the etiologies of visual impairment. Most of the causes were undetermined. Hereditary factors were responsible for 28 cases. This pie diagram shows the different preventable causes of vision loss. There were 13 preventable causes and the most common cause was trauma. This pie diagram shows the different treatable causes of vision loss. A total of 35 treatable causes were noted and the most common cause was pseudophakia with amblyopia. Coming to discussion. A preponderance of males over females may simply reflect a social bias towards educating males rather than a chromosomal difference in the prevalence of blindness. 16 children had no visual impairment. Similar findings have been reported in other contemporary studies as well. Developmental anomalies accounted for a majority of the vision loss, 29.32%. One may speculate that a majority of these anomalies are due to a genetic disorder which is common in these parts because of the practice of consanguineous marriages in this area. Developmental anomalies are also the commonest reported causes of blindness in other blind school surveys. Overall, the proportion of corneal blindness was very low, 5.3%. This may be because of a good coverage by immunization. In this study, 36.09% children were found to have an avoidable vision loss. Pseudophakia with amblyopia was the most common cause. Out of the 7 children with unoperated cataracts, only 1 was operable and was sent to the base hospital for further management. A similar proportion of lens-related anomalies has been reported from Cambodia and Malaysia. Although the proportion of congenital glaucomas was much higher than that reported in the general population, 5.3% versus 1 in 10,000, it is difficult to state whether this is a definite trend or a manifestation of Bergsonian bias. Refractive errors and amblyopia as causes of avoidable blindness simply indicate a lack of awareness among the general population regarding routine ophthalmological evaluation in children. Cicatricial ROP was seen in only one case, 0.8%. This may simply reflect high infant mortality rates, where ROP is rarely seen due to scarcity of neonatal care facilities. So my conclusion, the pattern of childhood blindness seen in this survey is very similar to that shown in previous ones, despite the unique socioeconomic characteristics of the studied region. The prevalence of preventable blindness can be reduced by strengthening the primary level services, but the prevalence of treatable blindness can only be reduced by improving pediatric ophthalmology services in the area with a comprehensive approach which should include early referral and rehabilitation facilities. Thank you.